recording.
All right. Is that another call?
No.
Okay. So we're going to now talk about different disease states in their EKG presentations. First one we're going to talk about is hypothermia. Hypothermia is defined as a core temperature less than 95 degrees Fahrenheit. You can have inhibited EKG tracings when they're mildly hypothermic due to shivering. Typical EKG changes are bradycardic in the kind of mild hypothermia. So sinus brady, you can have some AFib with slow RVR. You can get junctional rhythms and AV blocks. This is going from benign to more severe, okay, as they get colder. You can get Osborne waves, which I'll show you examples of Osborne waves. To me, it's kind of like a rectal thermometer. The bigger the Osborne wave, the colder they are. You can get prolonged PR intervals. QRS complexes can be prolonged, and definitively your QTC will become longer. You can develop VTAC or VFib. So Osborne waves. J waves, we know the J point is right here, and if you see that little dot right there, that is actually a little J wave. That's a benign J wave. You start looking here, it's getting a little bit bigger, that's more significant J wave. It's a positive deflection at the J point. Generally you're going to see it in the, you will only see it in V1 through V6. The colder they get, the bigger the wave gets, okay? So that's pretty mild, that's moderate. Now if we look at this patient, remember we had AFib, we had all these different characteristics. Let's look at this. So right there we know that they're brady. They're in AFib. We don't have any visible P waves. Look at that J point. That's a rectal thermometer right there. That's telling you that they're cold. And prolonged QTC. If you look, they're at 527. Okay? This patient is extremely cold. And we need to actively rewarm them. So it's kind of nice to just know that those are the characteristics you see with hypothermia. Remember, when you treat them gently. The colder they get, the more likely they're going to be pro-arrhythmic. The degree of hypothermia can greatly affect the severity of the EKG changes. Mild, generally you're tachycardic, it's a compensatory mechanism. Moderate, less than 90, we're going to get into those bradycardia, the prolonged QTs, PR intervals. The more severe they are, less than 86, you're going to get AFib with slow RVR. Everything's getting stunned. Osborne waves are going to be significantly pronounced. You're going to get a widening of the QRS complex, and they're going to, I won't say very likely, but they have a high risk of VFib. Anything colder than that, they're generally going to start getting into asystole. And just side note, remember they're not dead until they're warm and dead. Okay? So active rewarming, and I don't know what your protocols are for rewarming. Pulmonary embolism. Okay? It can be asymptomatic for a decent amount of people. Subjective findings, shortness of breath. They can have apprehension, even impending doom. Pleuritic chest pain. Your objective findings can be hemoptysis, cough, cardiovascular compromise. They can be tachycardic, hypotensive. They can be pale. Kind of histories that give you a high index of suspicion when you're dealing with patients. Any kind of long-term immobilization, if they've been in the ICU recently, long-term care facilities, any leg pain. Recent surgeries are huge. Generally, I think it's like 8 days out is what I see anecdotally. Long distance travel. Obstetrics, I didn't really think about this one until I was doing a little research, but it makes sense. They have such a huge increase in blood volume that obstetrics is high. Anyone that has a previous DVT or PE history is definitely prone. Hopefully they have an IVC filter in. Is everyone familiar with IVC filters? Okay. They're simple, very simple to put in, and they save lives. It takes us, once we get them on a table, probably 8 minutes to put one in. It's like super simple. Now getting them out is not simple. Think of a one-dimensional picture and trying to fish three-dimensionally. Because it's just 3 prongs, and then you have a little circle on top, and we're trying to hook that circle. It can be mind-numbing. And then, of course, age plus smoking plus birth control equals bad. Okay? So those are the people that are most at risk for pulmonary embolism. In an EKG, overall they're going to look pretty normal. About 40% of them are going to be tachy. Okay, S1, Q3, T3. We talked about this earlier, but we're going to actually look at it. Okay, you can have non-specific ST changes. You can have T-wave inversions in V1 through V4, and possible in 2-3 AVF. And you can have peaked P waves. How well can you guys see this actual EKG from back there? Do you guys want to scoot up? Because we're going to be looking at a lot of EKGs. And I try to make them as big as possible.
Probably have to dim the lights.
Yeah, can we dim the lights?
Absolutely. There's in the back.
Yeah, and just so you know, it's going to get interactive here in a bit. Alright, does that help? Okay, so you can get peaked P waves. Remember, we're looking generally in lead 2 for the P waves. And S waves, again, that S wave. So if we look at lead 1 right here, see that deep S wave and kind of bowing out there? That's a beautiful S wave right there. Okay? And Q waves in the inferior leads. So remember, S1, we have an S wave right there. Q3, can everyone see that Q wave down there?
Mm-hmm.
Big old Q wave, and inverted T waves. Okay? Right there, you see that in EKG, and they've had those risk factors that we talked about, the mobilization, long travel, obstetrics, all those kind of things. Your index of suspicion should go up for pulmonary embolism. They can also have right bundle branch block. Okay, remember we look in V1 for that. So here's I kind of enlarged it some so we can look at it. So we know that there's like, this one isn't too tacky, but we have that big S wave, Q wave, inverted T waves. So S wave, Q wave right there in 3, and inverted T waves. And we've got a right bundle branch block. So they're ticking all the boxes if they've got that clinical picture. Alright, pericarditis. So if we look here, this is a nice CT. This is actually the pericardium right here. Okay. You can actually see the split between the right and left ventricle, which is kind of a nice picture. So pericarditis is inflammation of the sacrum in the heart. Okay. It's characterized by sharp pain typically, not typically dull, not typically heavy, worsening with respiration. Their pain generally is worse when they're laying flat. A lot of times they like to sit forward or lean forward, and that relieves the pain. So this is where that kind of doing an H&P in the back is going to help you dial in that this might not be ACS and this could be something else. They can sometimes state that they feel like their heart's, they can feel it beating. You can get rubs. Typically it's more significant of pericarditis when you get rubs. And they'll have that elevated heart rate just because everything's irritated and their heart's beating faster. In pericarditis, all the changes can be variable. Okay, there's not a real clear-cut picture, but you can't have global ST elevation. So if we're taking a quick look at this picture, I've got ST elevation a little bit in 1, slightly in 2, nothing in 3. I got a little depression here, wouldn't call that much. A little bit in AVF. I definitely have V2, V3. So, you know, I've definitely got some diffuse ST changes, elevation. Nice little thing. I've never found a use for AVR until I was doing some research for this and talking to my cardiologist. If you go to AVR, okay, and you find your isoelectric line, if your PR interval right here is above the isoelectric line, that's actually indicative of pericarditis. So I was like, oh wow, I found a use for that. Because it's kind of, you know, it doesn't have anything in the injury patterns for ACS, it doesn't have any of those kind of things, but if you've got a elevated PR interval, and they feel like their heart's, you know, they can feel their heart beating, it's better when they lean forward, all those kind of things, and you got that, you're like, hey, I'm smart, I got pericarditis possibly. Okay? Left ventricular hypertrophy. Talking to my cards, they really wanted me to go over this with you guys because this is the most prevalent kind of EMS mistake is that they see this ischemic pattern in V5, V6. So I want to talk about this. If you guys have any questions, please ask away. It's a chronic change of the myocardium as a result of aortic stenosis, but most generally hypertension. Okay, so chronic. This isn't an acute change. This is over time. It's characterized by increased QRS voltage in 1 AVL and V4 through V6, and I got better pictures coming up. But you see how comparative to, like, we'll go V2 here, the QRS complex here, the height, and then we start getting to V5, V6, how high those QRS complex are, okay? And especially if I have it over here in V1. You'll have repolarization changes in the ST and T waves, and you'll have increased S waves in V1 through V3 over here. So you see all these have these really deep S waves, okay? And then we like to focus in, ooh, we got ischemia. But if I've got all those other characteristics and the other clinical picture is not telling me it's ischemia, this is most likely left ventricular hypertrophy. So look at that picture. My QS complex is really tall. Do I have S waves in my V1 through V3? Those kind of things, and I've got some changes, just ischemic changes in my ST, then it's probably not ischemia. Okay? So when we're looking at this picture, look at the height of the QRS complexes in 1 compared to 2, okay? AVL compared to AVF. And then V4, remember, is V4 through V6. I don't have much in V4, but V5 and V6 are definitely tall. Okay, I've got these deep S waves in V1 through V3. Okay, this is lead 2. It's kind of hard to see, but I blew it up a lot. Look at the widened P waves. And remember, peaked and tall P waves is right, widened is left. So that whole picture right there paints a nice image of left ventricular hypertrophy. Anyone have questions on that? And then, as a result, I have some ST depression in V4 through V6, or V5 through V6. I don't know why I mean V4 up there, sorry. Important of recognizing that. I'm beating it to death for my cardiologist, he asked me to. Remember, treat the patient, not the paper.
Now, did any of the cardiologists that you talked to, did they actually give, I've heard guidelines of as far as numbers for how deep that deflection is on your S wave to actually diagnose it as LVH?
My S waves in V1 through V3?
Yeah, I've heard if your downward deflection is 2 times what your upward is, then that would qualify, or is it just the overall picture that would? Because for us,
they didn't give me numbers, and there were a lot of different criterias and mathematical stuff that I didn't add, and I don't actually remember. But again, if your patient has active chest pain, they have this and that, and they have that, treat it. But don't be like, oh, you know, it's game on me, you know, but they're just feeling fine and have general malaise. So again, make sure you're treating the patient, not the paper, but just being aware of this when you're looking at the picture and it's not making sense, just kind of cluing in your mind, like, look at what's going on here, I got S waves, okay. I'm not as concerned, but I'm not saying dismiss it. So, you have a question?
Yeah, did they talk at all about the concordance or discordance piece of this too?
I didn't. So.
That's a newer concept some people we've been talking about now, you know, is a concordant, discordant, and the chances of it being bad or not bad, basically.
Right. And this is one of those places where access can come into play, but I didn't include it. And I will say that I'm weak on access. Okay?
Well, yeah, that's...
I will admit my faults and my deficits.
Well, the only reason I just have the question is, you know, for our criteria, you know, we would not typically activate the Cath lab for elevation in the presence of LVH is the kind of black and white answer to that question. But maybe the answer is to recognize what the pattern normally looks like for LVH, and then if we're seeing something that's different from that, maybe we would forward that EKG to the hospital and have them kind of make that determination.
I agree with that. And even the cardiologists bitch about the ER docs and they're reading the EKG, so
Yeah, and
it's everyone is how they're going to read it.
Okay.
It is, but transmitting and giving a picture and they're like, yeah, then you're good. But
Yeah,
at least they just mainly he wanted me to mainly have you guys recognize kind of that pattern there.
that is normal.
That is normal with what, and especially if you see that kind of wide P wave too,
Is
that
actually
that it kind of paints a whole picture.
okay.
Excuse me. So ups and downs of potassium. Hyperkalemia is defined initially as greater than 5.5 milliequivalents per liter. Pathological changes, you have repolarization abnormalities. You can get the peaked pointed T waves. With moderate hyperkalemia, which is greater than 6.5, your atrium starts becoming paralyzed. And what's kind of interesting is your atrium is paralyzed, but you're still getting P waves. But your atrium isn't actually contracting. It's transmitting the electrical activity, but it's not actually having the mechanical activity as it starts developing. Your P waves will flatten out. Your PR interval becomes widened, and eventually you will lose that conduction, okay, with moderate hyperkalemia. Severe hyperkalemia, which is greater than 7, and I've seen people that look pretty normal because they're chronic with a 7, 7.3. It's the new onset that's going to be really scary because their body is not used to having a 7 or greater potassium. Those are the ones where you're going to start getting sine waves and that. The chronic ones, I've seen potassiums like 8.8. So, and the EKG didn't look good, but I've seen people that were new onset that were in the 6s that looked horrible. Okay, you will get conduction abnormalities with AV blocks. You'll get a progressively widening QRS, right or left bundle branch, and the late stage of that is a sine wave, which I got some images of that. You get high AV blocks, sinus brady, AFib. So when we're looking at this EKG, we can see, so this is a perfect one where you're looking at your pleth, because this is going to be counting this as, you know, probably 160, 170 heart rate kind of thing, because it's looking at the QRS, which is here, and these T waves, and you can see we have, is that a P wave? What is that? Go up here. I don't know that that isn't a U wave, because it's pretty damn big, okay? So I've got a prominent, which a U wave is normally hypo, so that's an interesting picture. So that might be the P wave, but I've got these huge peaked pointed T waves. Normally you're not going to see them like dwarfing the QRS complex, but you can. You can. Okay. Lead 2 is where I like to look at it. So when you look at this one, okay, we have a left bundle. Does anyone see any P waves? Widening QRS with the bundle, obviously. Is this an accelerated junctional? Is this a hyperkalemia? What is this? You know, but this is where doing your assessment, kind of figuring out what's going on. Oh, they've had this malaise. We really wouldn't do it for you, but oh yeah, he's been sick. You know, they've been saying something about his kidneys. Oh, uh-oh. So hypokalemia. Okay. It's a serum potassium less than 2.7. You will decrease the extracellular potassium, which leads to hyperexcitation. Excuse me. You'll get a widened P wave. You can get inverted T wave. You will get that U wave. So I bet you that those were actually the P waves because you can't have both. Low and high potassium. You can get ST depression, and remember, MAG follows K. So if I've got low MAG, I've got U wave or low K with, or I suspect low K with U waves. If I have nausea, vomiting, diarrhea, those kind of things, I got U waves. I got to be concerned for low MAG. So when we're looking at this one, look at the U wave in the precordial leads, pretty prominent. Okay. Any questions on that? COPD. The pathological changes with COPD. As the patient has the hypoxia, they get increased, and those inner thoracic pressures, they have increased pulmonary artery pressures, which results in right atrial enlargement. So we're going to have those peaked P waves. We're going to get right ventricle enlargement. Hyperinflation, because their lungs are so big, you'll get dampening of your precordial leads. And because their lungs are so inflated, their heart actually turns. So that's why you'll see on these COPD patients, your QRS complexes and your voltage is small. It's because of that hyperinflation and the torsion of the heart. So again, peaked P waves, especially in the inferior leads. Sometimes you can get the flattened and inverted P waves in 1 and AVL. You can get sagging or dipping of the PR and ST segment below the isoelectric line too, which I got a picture of that. And the right ventricular enlargement can develop into a right bundle. And as I said, the dampening of the precordial leads. So when we look at this, we've got that sagging, you can see right here. We would normally have that isoelectric line right there, but I've got this PR sagging and I've got the ST sagging right there. So that's a pretty good picture of what you can see with some of the COPD patients. We can see the peaked P waves right there. You know, this person's got a 20-pack year history. Oh no, I don't have COPD, emphysema, or anything like that. You kind of see this picture, like, want to bet? And then you see the voltage in your precordial leads is dampened. So it's kind of nice to be able to just see that and kind of get a clinical picture really quick. I don't think it's going to change your practice, but you can feel smart. So when we look at this one, look at lead 2, the P waves. Those things are smoking peaks. Okay. Look at the dampening of your QRS complex over there. So that's a nice clinical picture of COPD. And then you can see, let's find a nice isoelectric line. So you can see that sagging right there. And you know, it's hard to do with an ST segment, the sagging, but you definitely can see it in your PR. All right, so for you guys, what does a cardiac cath lab want from you guys as people that work in the field? Okay, early recognition and activation of the cath lab is key. Okay, if you can't transmit, call, paint that picture. Tell us, hey, I've got this, they're presenting this way, this is what I'm seeing on my EKG, I can't transmit. Leave it up to the ER doc. Let him make that decision, and I'll talk about why that's important. You know, if you activate and it's wrong, it's not a crime. You know, if you activate every single patient, yeah, we're going to get a little annoyed with you. But if you activate on good faith and you miss something, it's not a crime. You know, what's better for the patient? That I get in my car, get out my PJs and haul ass to the hospital and they turn around, or that I'm there when they need me, you know, and that we can intervene quicker. So activate, you know, paint that picture to the doc. And we, you know, everyone knows here, you can get almost anything you want if you can paint the right picture. So, you know, just be good at painting the picture of what you're seeing and what you're concerned about. Serial EKGs paint a picture, like I've talked about earlier. Make sure that you are getting serials when you can, when time permits, because that's going to allow us to see, and it actually shortens our decision-making process. That if we see serials and things change, and I was talking to the captain, even if you do an intervention like, oh, I'm pain-free, get an EKG. So you can see, hey, look, nitro and morphine did this and we got these changes. Boom, that's huge because it helps us with the kind of how stable they are, how soon we need to intervene, do we need to go now, do we need to let them cool off a little bit. There's a lot of different things. So the serial EKGs are important. 2 large bore IVs, okay? Not 16s. I will cheat and say a 20 is a large bore. I know in the EMS, 20 is not a large bore, but I've had some EMS, not from here, that have put in 22s on a STEMI, and I just want to keep them. Avoid the risks. There's a trend that we're going through radials a lot more, especially at Carson. And if you put anything around the wrist, the way we close the artery after we're done is we have like a band, it's almost like a wristwatch band that we put over and then we inflate and it holds direct pressure on the radial artery. If you have something right around the radial, I'm ripping it out. Okay, it's gone, and so I've lost time. So ACs, we love ACs, put them on both sides. If they haven't had any kind of bypass, so cabbage, you can go left wrist if you need to, but stay away from the right wrist because we primarily go through the right wrist. Make sure, this drives me, I'm going to cuss, batshit. Don't direct plug into your IV. The reason is my table is 10 feet long, about. I have to put extension tubing on my IV tubing so that I can reach my patient to my pole. So if I don't have that, I got to break it down and attach it. If you have secured it down directly to the catheter, I've got to take it all the way down, hold pressure, hook up new tubing, all those kind of things, redress it, and that's wasting time in me doing the intervention. So put a pigtail on. I don't know if you guys call them pigtails, but put a pigtail on any of those guys because it's hugely important. And that extension tubing, I know you guys don't carry it. I don't care. You know, if I got the pigtail, I'll plumb my own stuff, throw yours to the side, and hook in, and be good to go. Okay. But breaking down that dressing, we're going to talk about the time frame of getting into the cath lab so you guys can kind of see how early activation is important. Aspirin. Give them aspirin. If in doubt, give them aspirin. You know, aspirin doesn't hurt. If they're STEMI, and I'm not a doctor, so I'm just saying this, but if they're sensitive to aspirin and they're having ST elevation, I don't care. You can have an upset stomach. You know, I don't care. You know, the benefit versus risk is huge. Okay. So this is the 90-minute door-to-balloon breakdown for a patient that walks into the ER. Okay. We have in the ER 10 minutes for us to determine that they need an EKG and get it done. Okay. It takes about 5 minutes from the doc looking at it to calling the house administrator to us getting our phone calls that say, hey, we need you, we got STEMI. Okay. We have 30 minutes to get in. Okay. We generally get there in about 20, but we have 30 minutes. Weather, traffic, accidents, those are all things that play factors in it. And if we don't get to the 90-minute time because of accident or weather, whatever, it's not the end of the world, but we really try to make it. Then we have to set up our room because we can't leave our room set up. Once you wet a sterile table, the clock's ticking. So we don't set up tables because we don't know who comes in our rooms. So we can't keep them sterile. So we have to pretty much we'll have a lot of our gear set up, but not the actual table. So that takes us about 10 minutes to set up. Then of course we got to go down to the ER, get a report, throw them on our monitor, and get them back. Okay. Then we hook up a lot of stuff on these patients. I mean, some of you guys have brought them directly in. It takes us about 8 minutes to get them hooked up and ready to stick. So if you look at that, we have 19 minutes to intervene. That's all we got. 90 minutes. We have 19 minutes to do it, to make our time. You guys call early, guess what? You've saved me this much time. Say you guys got like a 12, 14 minute transport, guess what? Now I've got, what, 34 minutes to intervene? So the earlier you guys activate, the better off. We can be on our way, we can be in, we can avoid this 10-minute for getting the EKG, 10-minute for activation, or the 5-minute for activation. That's still going to occur, but we're going to be coming in, you know, and cutting out a lot of this section. So the quicker you guys call it in, the better off, okay? So let's do some practicing. I've got a couple of scenarios which we actually have kind of a, not an H&P, but a hospital-based term, sorry. But we've got a 70-year-old male, chest pain with cough times 5 days. So vitals, blood pressure 185 over 98, heart rate in the 80s, setting 92% on 2 liters, respirations 20, little warm 100.4, general appearance warm flush, wake alert and oriented times 4, but general malaise. Your ample, pretty basic. He's got a history of hypertension, COPD. The events has been progressively worsening. It happened 5 days here, 2 days there. All right, pick, you guys can choose. It's worse with cough and it changes with palpation. It's sharp, it's non-radiating, and it's 6 out of 10. 5, 2, 3. I didn't look at the slide very well.
It's a poor historian.
Yeah. So, come on up and look at the EKG. Here's your pointer. Tell me what you see. And you're each getting it. So the laser is this button.
Speak up too.
Yep.
Okay, so.
And you guys are all on video too.
Nice. So initial suspicion just based on the history, I'm thinking infectious source of some sort. He's got infection, or he's got the temperature, he's got the cough, plus the pain. With the way that he's describing the pain, that it's sharp, non-radiating, I would think we've got a potential for like a pericarditis. Would be odd to see, but he's definitely got potential. As far as the EKG is concerned.
So remember, try to use those systematic steps in here. Here's a cheat sheet for you.
Okay, do you run through it? Okay, so looking at this EKG, just first thing I would see is our rate is normal. It's definitely regular. We have P waves. They have correlating QRS with it, so I would say this is a sinus rhythm.
Okay.
Based on probably 70, 80 for the heart rate. So I would say we've got normal sinus rhythm. As far as ST segment changes on here that we can see that we have a really subtle ST elevation in 2 and 3, which can be pathological. However, we've got some subtle elevation in V1, V4, maybe 5 and 6. So I'd say we have those diffuse ST elevation that's really, really moderate. Otherwise, I wouldn't see anything in here that stands out to me. Everything else
so
is
question,
normal.
where do you see, show me where you, where you see the ST elevation in V3, V4.
V3.
So find J point in.
So this, I would say, maybe
You
like
can
right
get closer.
there. I'm gonna need to because I can't. I shake hands. I would say that right there is my J point. So I would say that I've got maybe like half a millimeter.
Okay,
Maybe even meet the one.
Maybe.
Mm-hmm. And so otherwise, I don't see anything else that would stand out to me. I don't see any sort of Q wave here that would indicate previous history for being 70. Overall, the EKG looks pretty good. As far as this pattern here, we've got the higher amplitude. I think that would probably indicate maybe like a COPD type history, but.
Well, we do have those S waves, so and then we have some increased amplitude, but no depression. So yeah.
Yeah.
So
So I would
what's
not see it. I would not see anything on here that I thought was acute.
Okay. Let me see the button. Let's see what she's right. So first impression, you said otherwise pretty normal. So overall looks pretty good. You said about 85, so it's pretty normal. Okay. PR interval.
It's normal.
Okay. So QRS, so PR is good.
Yeah.
P wave morphology. What do you think?
Normal.
Okay. Slightly widened, but not much. You know, not enough to have an issue. You already said
So no bone
no.
reaction.
Okay. ST elevation. You said primarily in V2.
Yeah.
But not concurrently. Okay. So any of the T waves peaked or inverted?
They're a little bit peaked, but I think that is pathological with what we're seeing with that little elevation in V2 and V3.
But you got to also remember where they're peaked. Is it significant comparative to the QRS complex?
No, as far as
Okay. So I say no. So those are normal signs. So it's probably an infectious process. Okay, come on up. Here's your next one. This is your patient. Go to town. So here's the laser pointer. Laser pointer, and then once you just click to go, actually I'll click between the slides. So just 92-year-old female, weakness, blood pressure is a little low, 92 over 52, heart rate's 40. That's kind of concerning to me. 92% room air, respiration's fine. Cool and pale, but awake, general malaise. Okay. Here's your sample. So see the list, but she doesn't give you a list, so enjoy that. So just feeling poorly for about a week. Okay. So here's a laser pointer, and go ahead and go through this. If you need a cheat sheet for the kind of the steps, yeah.
Alright, so rate and rhythm looks a little bit slow. She was rated 40. Looks pretty regular though.
Why do you say it looks weird?
The
QRSs.
QRSs.
Okay. Fair enough.
Let's see. Obviously, I'm trying to look at the. And then P waves. There's are possibly more P waves than. Or it looks like I'm thinking third degree block based on just looking at it, but
Okay.
I don't know jumping ahead.
Well, and that's your first impression. You
Yeah,
can
that's-
obviously have your first impression
That's
and
what's
then
kind
go
of
through
hard
the
to break down after I
Yeah.
kind of have my assumption, but trying to
And
describe
that's-
what it is that I'm seeing.
That's what a lot of people do. They get their first impression and just
Run
wipe
with it,
everything else.
But so what was I looking at? So QRSs doesn't appear to be widened.
Okay.
Like I said, the P waves they appear normal, just don't always seem to be corresponding with the QRSs.
Now you said the QRS. What lead do we look for the QRS complex typically? V1 is close. So if we look at that, it's close. Because what do you remember the number?
0.12 or
Correct. So how many boxes is
greater than that? 3.
3. You can go get closer if you want.
Then it's pretty. Yeah, it's right on that border, like
Right.
3.5.
So and then a downward deflection in V1 is indicative
of
of.
the left on a branch.
Okay.
So, and then T waves. Well, because of it's a bundle branch block, sometimes too, these comes to the concordance, discordance type thing, where
Right.
there's some criteria that would meet. Normally, if it's discordant, it's not an MI. It's a member, but so. The left bundle branch block, but it also appears to be, to me, 30 degree still.
Right, which you normally can have widening because, and so the interesting thing that gives it away to me, if I can see the pointer. So when I always love lead 2, come down looking at lead 2. If you take a piece of paper and make the dashes where you see the P waves, boom, I think that's a P because look at the morphology, boom, boom, and you just walk it out and you see, oh look, the P waves are rocking along and the QRS is rocking along, but they're not talking, boom, 3rd degree. And the clinical picture, when you go back, heart rate of 40, general malaise, kind of thing, blood pressure a little bit close to the crappy side. So first impression, you said, I'm worried about a 3rd degree block. Okay. P wave, abnormal P wave intervals. Okay. Heart rate and rhythm, you said it is slow. Okay. PR interval, QRS, and QT. We didn't really talk about the QT. Not going to worry about the QT here. Okay. But it's less than 50% on the QT. QRS we talked about that is right at the 120 milliseconds, and there's more P's and QRSs, so it's kind of hard to do a PR. The morphology, oops. Upright, it's similar morphology, not widened that peak. Okay. We talked about that is a V1. We've got a left bundle branch, and consider accelerated junctional. And the ST segments kind of get thrown out the window slightly on a 3rd degree. Okay. But I do have some, in B3, so. Nope. So, 3rd degree. Good job. Who's next? There's only a couple.
Kevin?
Oh, yeah.
Not quite.
He's a
not quite. Not there. Volume want to show off?
No, but I'll do it.
Everyone up? This isn't to embarrass you, it's just to get everyone thinking. You want to come up? 'Cause then you can use the pointer.
Back. Yeah, perfect.
Just totally sidekick.
If I have to be on YouTube, you have to be on YouTube. Alright, so you have a 45-year-old female, chest pain times 2 days, blood pressure looks good, 125, heart rate slightly fast, not really going to worry about that too much. Saturday 96 on room air, respiration's 20, pink, warm, and dry, awake and alert, in obvious pain though. Okay, no allergies, on birth control, progressively worsening pain. So it started, hey, look, at least they match, 2 days, 2 days. Onset 2 days ago. With movement and deep breathing, no change with palpation. It's sharp. It does not radiate. It's 8 out of 10. So based on this picture, just talking before we ever get to EKG, what's kind of going through your mind as a differential?
Probably the P,
Okay.
because of birth control, older female.
Yeah. Good job.
Pain with movement, deep breathing, blood pressure good, elevated heart rate. That's just from the pain she's in. The sharp pain.
Yeah, I think that's a good clinical assessment of things that I'm going to have as a differential. Now look at the 12 lead. So when you're looking at this, here's a cheat sheet if you want. So what's your overall impression?
And there's elevation all the way throughout.
Okay. Does the patient's condition match this EKG? Are they too stable or are they sick? Based on the previous slide. So when we look at this stuff.
She's stable, progressing towards sick.
Okay. So that's the first question is like that I'd ask myself if I saw this EKG is because what am I going to see with the patient if this was cardiac? So they're going to be sick as shit.
Yeah, you're gonna have different blood pressures and
Right. Okay.
stuff like that.
Heart rate and rhythm, is it fast? Is it slow?
Fast.
Okay. This one is about 85, even though it said on that previous slide. I couldn't get all my EKGs to match my numbers. So just go with it. Okay. PR interval, QRS.
That looks all within the specs of normal.
Okay. I agree with that. So the one thing is there's a shortened
So
PR
it's less than
than 0.12. Well, for a shortened PR interval, it's slightly shortened. So to be shortened, it'd be less than 0.12 milliseconds. So if you look there, it's pretty close to banging onto the
right
QRS. Okay. QT. If we look at, I just grab say 2 again. I take my R, find my end of my T wave, boom, that's less than half, good to go. Okay. P wave morphology. So again, I would look probably in 2. Looks pretty similar.
yeah,
Is it rounded or is it peaked? Is it widened?
not really.
Not really. Okay. Upright, similar morphology, not widened, not peaked. It's good. QRS complex, is it widened?
No.
Okay, so no. ST segment elevation,
Everywhere.
everywhere.
Except for 3, maybe,
Yeah, nearly global. Okay. Are the T waves inverted or peaked? It's kind of hard to tell. There's a potential up there, and so yeah, I would say that they are slightly, but why is that? You know, I put no, but now I look at it, I'd say possibly yes. Okay, so your initial,
yeah.
you know, based on your assessment, you were able to go and bang away and see that yeah, most likely that's pericarditis.
Mm.
So one last one. Who's coming?
I just dropped
So you got a 36-year-old male, chest pain times 30 minutes, blood pressure low, 88/50, heart rate 70, 96%, breathing a little fast at 24, cool, pale, awake, alert, and obvious pain. Nothing for medications, past medical history, allergies. Okay. It doesn't change with movement, it doesn't change with palpation, it feels crushing, and it's going down his left arm. And it's 10 out of 10. So what's your general impression just from this assessment?
Cardiac.
Okay. Why?
No change on palpation, and provide it's crushing, radiating to the left, severe sudden onset, low blood pressure,
All right, I
reduced respiration.
agree with all that. So what's your general impression on this one? And this is an advertisement for Learn the Heart.
We got definitely have elevation.
Okay. What leads?
2, 3, reciprocal AVL, AVF is elevated.
Okay. And what What injury pattern is that?
Anterior.
Inferior.
Inferior.
So hold that up to your heart, this to your sternal border. That's inferior. Okay. So your snapshot, you said you've got ST elevation 2-3 AVF with some reciprocal changes. I wouldn't really call that, but yes, I call that. So inferior. Okay. Is it fast? Is it slow? Is it normal?
No.
Okay. Agree with that. PR intervals, prolonged, shortened, anything? Okay. Might be, looking at lead 2, might be a little long. So it's slightly long, so he's got barely a first degree block there, but it's enough that I wouldn't stress on it too much. QRS complex is less than 120 milliseconds. The morphology, looking at lead 2, they look pretty similar. Not peak, not widen.
They're not wide and they're right.
Okay. Okay, I agree with all that. How about the QRS complex? Is there a bundle present in
No.
B1?
No.
No, okay. And we already talked about ST elevation in our
Multiple.
first, yeah. Alright. And I say no. Okay. Inferior
Inferior
MI.
MI.
Yeah.
Cath Lab.
Yeah. Oh, I have one more. Do you guys like these?
Yeah, that's
Okay.
great.
How about one? I think this is my last one.
So
the one I did?
same
That
point,
looks really
yeah.
familiar.
Yes.
It is not. It is a
Oh.
different 90-year-old.
Okay. same
Because this
point.
is different. Okay.
Okay.
Should I make the captain do it? You know how to use the clicker, so it's all yours. So boy, it looks really familiar. Okay.
So Phil's poorly for a week. Cool Dale, John Lays.
Okay, so here's your EKG. What's your first general impression?
So my snapshot would be a little slow, maybe. Wide complexes,
Okay.
and I don't know if I see, looking, I'm missing some components. I gotta just look deeper into this EKG for my general.
Okay, I agree with that.
My heart rate is, I could go. That was me saying, I guess I'm looking for. So it looks like it's a little slow using triplicate. It's hard to tell. Normal.
So you think 300, 150, 175. So fourth box is 75.
Okay. So then we're normal heart rate.
Okay. Do you see any P waves?
I really don't. Not on this tracing, no.
I don't either.
Okay, so I don't have a PR.
Okay.
QRS is wide.
Okay. This is a busy EKG I gave you.
Yeah.
Okay.
And then it's, if like a V1, it's left. If I was, yeah, it's left.
Okay.
So, yeah, greater than 120.
We talked about
We
it.
don't have P's. So we're going to go with the QRS is wide on this, greater than 120, and it's left.
Okay.
Double branch.
And there's some big S waves in there that makes everything difficult.
Okay.
So
As far as ST segments, yeah, I mean, I got just a whole lot of business. I got depression, it looks like, in some areas. Like 1 flips, flipped, inverted in 2 and 3. AVF a little bit.
okay.
And my V leads, like V1 it shows elevated, but it's discordant, so yeah. I don't know.
Okay. This is a hard one. That's why I gave it to the captain.
Yeah, I got. Looks like to me it would be depression in like V2, V3, V4 with big peak T waves. So.
All right. Where are you seeing the peak T waves primarily?
V2, V3, V4, sort of V5, but those three primarily.
Okay. That's good.
Okay, so yeah, S is different.
Okay. And you just talked about the T waves,
Yeah.
so good. So in the precordial leads, we have significant peak T waves.
Right.
So what is that significant for?
Hyperkalemia.
Okay. And then here's a little picture that, so that patient there had a K of 9.4. Okay. Patient received 5 amps of calcium gluconate, 20 units of insulin, 2 amps of D50. Do you guys know how all that works? Okay. And 2 amps of bicarb. 1 hour later, there's your EKG. So let's go back. Oh, actually, I think I did. Hold on. I gave you that. So this is an hour later after receiving those meds. Obviously, they're going to have to be dialyzed. Those meds are short-term, interventions. But so it went from that to that. So, and for this, the first time I looked at it, I was like, that's a lot of business going on there. So I had to really slow down, and until I cued in on these T waves, widened QRSs, they weren't really slow, lacking P waves, all those kind of things, I was slightly baffled for a few seconds, and then I was like, okay, and boom, you start going down that checklist of what you're going to get with hyperkalemia. And if you look back on the notes, you're going to have, they're either going to kind of go into fib, you're going to lose those P waves, you're going to get a widening of the QRSs, I'm going to get peaked pointed T waves, so we hit all those boxes in here, but it looks like a whole lot of stuff going on, so it can kind of distract you and overwhelm you. But if you take it systematically, you can start going, I think this is what it is. So, oh damn, I did more. All right, so I'll do this one, so I'll save somebody. 58-year-old male, found down, blood pressure is 90 by PALP, because you guys love doing PALP. Heart rate 20s, setting 90% on room air, respirations 8, pain we're unable to determine, pale, cool, unconscious, okay? We don't know anything, because no one found him there just laying on the street. So, I've only got a 3 lead on him. And I'm looking at this, and the first thing I'm going to do is I'm going to check a pulse. Okay? But I do have a pulse with this. I'm looking at it, do I have any, my general impression is that's awful wide, I don't see a P wave, and it's getting slow. So that's my first impression. Is there a pulse? Okay? It's slow. PR, I have nothing for PR, and those QRSs are significantly wide to the point I couldn't definitively say they're QRSs. They're starting to flatten. As you can see, especially down here. Okay, flattening off, they're not peaked anymore. I have nothing for P's. QRS widen right or left? It's a, if I could call it a left. Well, I mean, because I don't have V1 to do, so all I know is it's widened on here. ST segment elevation, couldn't tell you. T waves inverted or peaked, couldn't tell you. So that's late stage hyperkalemia. That was that patient that we saw before that wasn't kind of a chronic renal patient that is a new onset renal patient that is at 7. So you think that other one was 9.8? But they had the peak point T waves, but they're close to 10. High range is 5.5. This is probably the patient at 7, but they're new onset, and they just widen out. And I had saw a great sine wave EKG that came out of a hospital that was near a naval air station, and the EMS had looked very similar like this. EMS had been given amiodarone and all those kind of things, thinking that it was like a wide complex tachycardia, but was not tachycardia, it was a bradycardia. And turned out his K was 6.7, that is new onset. So as soon as they started correcting that, boom, everything started tightening up, P's came back, so forth. So, and that one's fixing to die. The funny one, the one near the Naval Air Station, great pulses, great blood pressure, but it literally looked like a sine wave, and you're like, how is that happening? So, all right, you guys want a break? All right, so this is actually a patient that you guys brought in on Monday. So we're going to kind of look at it.
That's one of our 12s?
No, this is here. Let me.
I was like,
This is the. Let's see if I can find.
I was like, that can't be ours. That's too clean.
Where's the icon? Where's the? Okay, perfect.
Can you maximize it too?
Yeah, I will.
Thanks, dude.
All right,
Oh.
and I'm going to zoom in
That's
on
the
here.
new-
This is what you guys initially transmitted.
That's in the fill.
So when we're looking at this, we're looking at lead 1. Okay, we got P wave present, nothing's jumping out at me. There's a lot of artifact going on here. And I'm looking across at it, jumping out to me. We see that we've got the V2 right there, V3, and the strip got cut off. So I can't really see any of the ST there. That's what you guys transmitted. Okay. This is what we did in the ER. How's that for you guys? Pretty good.
Good.
All right. So general overall impression is it's normal for the rate. I've got a P with every QRS. My QRS is narrow, but I've got a downward deflection in V1, and it looks like 2 boxes. But then what's popping out to me is I see V2, I've got my J point right here. So I got ST elevation in V2. Don't really have anything in V3. You know, not really anything V4, V5, V6. So, and I don't see any possible little depression over here in 3. Possibly some reciprocal changes over here, but this one's a hard one because when you look at it, I don't have reciprocal changes, or excuse me, I don't have concurrent leads because I've just got the elevation right here in V2. But I do have some ischemic, you know, reciprocal looking changes, but very subtle in 3. I've got this swooping down here too, which I don't know if I call that, and a little bit in AVF. Okay, so this is, and she's a 59-year-old female. When we took her to Cath Lab, okay, do you see this shadow? You guys can see my, yeah.
Mhm.
See this shadowing right here?
Yeah.
There should be a vessel right there. This is 100% LAD. Okay, coming down. So what we're looking at, I'll go to the next slide. So here's another angle, and it's really hard in the cath lab because you think that patient's laying on the table flat, and then our tube is rotating around them. So every angle can look slightly different, but what we're trying to do is get a good visualization of it. Because if we're shooting from one angle, it can look fine. We rotate and we can see that it's actually occluded on the bottom or the side or whatever. So we'll shoot numerous angles of each vessel. And I really try to get some video and get some good ones of you, but it's going to cost me $800 to get the program to be able to play it, and I wasn't going to do that. So there's another angle. How do I get out of this? Okay. So this is what it looks like when we go in with a balloon. So you can't really see the vessel because we're not shooting contrast. The reason you can see all those vessels is we're shooting a liquid that has a high molecular salt weight that is denser than the surrounding tissue, so that's how we visualize a coronary. Well, when you're going in here, this is our interventional tube. Okay, we have all these different catheters. It's like little plumbers. That's all we are, and each one of them has different angles to allow us to get into different turns. But what he'll do is the doctor will advance a wire through the lesion. Typically, here's the thing: if it's an acute, the lesion is soft. We can poke through with the wire and get through. If it's a chronic, the doctor can actually kind of feel. You can feel that it's hard and crunchy, and that we know that we might not be able to get through. We might attempt, but on a fresh occlusion, we can generally poke a wire through. Then we'll advance a balloon down. So this is the balloon actually inflated. So he'll go to the point where the lesion is that he can detect, inflate that balloon, and it'll, you know, your arteries, like anything, they expand, you know, and that we can open it up. The thing that gets fun in the cath lab is you release a bunch of toxins. So they'll start getting a lot of ectopy. I shock people chronically. I'm actually bad because I'll shock them before they go out. So then they yell at me, the patient's like, don't do that again, please. So it's kind of fun. But we'll go dilate it, and then we'll go in, and based on our catheter size here, because we know this is a known diameter, we can measure the vessel, figure out what size stent we want to put in. And all a stent is literally, if you think of a mesh and a long tube, we can do, like, on the right, we'll do like 38 millimeters long, which doesn't seem very long, but when it's in there, we're doing the vast majority of the right. So we'll kind of figure out how long the lesion is and how much we need to take down. We'll throw a stent in there, and we'll inflate it with a similar balloon. So this is without the stent, because we just want to open it up. Then we'll sink the stent down and inflate it, and we'll get better flow that way, and it holds it open. The importance of giving them the antiplatelets, I'm taking the Ethione's, Plavix, all those kind of things, is to stop the platelets from binding to that stent. And you know, we see, I wouldn't say a lot because we really pound it in the patient's head, but we'll see these people back when they say, oh, I felt fine, so I stopped taking my meds. It's like, oh, well, strong work. So this is what it looks like. So look at this picture again. See right coming down here, okay? And then we're gonna, this is after we opened it and stented it. Okay, so we were able to open, remember we just had that little nub right about here. We went down, passed the wire, inflated, and because it looks different, it's because we're at a different angle of the tube. But we opened this up, LAD goes all the way down to the apex, where the circ kind of goes around to the left side of the heart. And the right coronary, if you're ever looking at films, always looks like a little C-clamp, looks like that. So, but it's challenging even for me sometimes. I'm like, is that the circ or the LAD? Because of all the angles we are going at. But a nice way to cheat if you're ever looking at this, if you see it going to the apex, it's the LAD. Okay? So just want to show she had great outcomes. She was the patient that when we went in, she was sick. She looked sick. She was gray. She was pale. By the time we opened that up, she was laughing and joking with us on the table when we were pulling her off. It was like, wow, you're feeling better. She's like, I'm so happy to be alive. You know, because she had the impending doom. I mean, but you saw, looking at that EKG, that was one lead. But so let's go back and look at that EKG just for a second. You know, LAD, and I talked about earlier that only V2. Okay? You wouldn't think that that's 100% LAD from that EKG. But cueing in on the reciprocal changes that are possibly going on here, her clinical condition, she looks sick. She was gray. You could tell she's in significant pain, and we've got this right here, okay? So every patient can be slightly different, you know. Presentations, I mean, it's nice when you get that, you know, ideal presentation that clicks all the boxes. But knowing your patient and then kind of cueing in that this isn't right, and hey, look at this, you know, that's pretty subtle. You know, how often are we going to pick that up in the field? But if you have that time during transport, they look sick, spend a little extra time, okay, and pick that up. But she did great outcome, and you guys activated before. I think you activated 5 minutes out, is what you probably activated 10 minutes out. I heard 5 minutes out when I got called. But we ballooned her and had her reperfused within, I think, 52 minutes from the time you guys she hit the door. So. And luckily, I was still at the hospital. The rest of the team wasn't, but I was able to get the table set up and everything. So she had a great outcome. Okay, but it's those subtle things too. So really try to cue in on that. Take an extra minute to look over that EKG, because you can be like, well, I don't have concurrent leads. You know, I don't know what this is, but I'm not going to activate. But they activated off theirs, which had a little bit in V3. too. But it can be subtle, and that was 100% LAD. Okay. So we're gonna do a little practice here. Found that picture for you guys. So when we're looking at this one, this is gonna be group. So everyone please speak up, or we're gonna be here a long time. What's your first impression when you're looking at that? I can't hear everybody.
Elevation.
Where do you see elevation? What leads?
B2, B3,
Okay,
B4,
okay.
5. Got inverted T on 3 and a little subtle on AVF,
Okay.
maybe.
So I'm looking at, I say it's sinus, right? Okay. I definitely see in lead 2 these peaked P waves, which is indicative of what? Right or left atrial enlargement? Right.
Right.
Okay. My QRS is narrow. Okay. Do I see any Q waves anywhere?
No.
Okay. So you said the ST elevations and the T wave, we have some inversion. Okay, AVR is normal to be inverted. Okay, but that's not normal. Okay, so we've got a Brady because we go 300, 150, 175. So we're slow. Pretty quickly we get that, and we get the elevation. So what kind of injury pattern is this? Anterior. Inferior. This is anterior with a little bit of going into lateral. Okay.
Maybe some reciprocal issues inferiorly, right?
Yes. So if you remember, if you look at the handout I gave you with the anterior and lateral, you can have reciprocal changes in 2-3 AVF. And if you look 1, you can actually see right here we got a little elevation right there. So if I start at 1 and I see a little bit of elevation right here, I automatically go over and look at my precordial leads and then come back. Because I know my injury pattern for a lateral is 5, 6, 1, AVL. Okay? But and you know anytime it happens on the left side of the heart, you're going to possibly get reciprocal changes on the right side of the heart. Okay? But good. Let's go on to the next slide. So, what's your general impression on this one? A lot going on. Okay? So let's look. My general impression is I already see 2, 3 AVF, which is what? Again? Inferior, correct. And then I see if I've got ST elevation, then this is reciprocal changes in AVL, V3, V2, a little bit in V1, a little bit in V4. So that's my quick snapshot is that I got an inferior. Then I'm going to look, go to lead 2, my P waves, they're a little big. I don't really care. I've got an inferior, but I'm still looking. My QRS complex is narrow. I've got a little, this is a, it's just a flipped QRS, not a bundle. So right there we've got an inferior. Okay, and then I might look at the QT a little bit. RR less than half. Boom. Okay. All right. What's your general impression on this one?
Elevation
And what leads are you seeing them on?
V1 through V5.
Oops, excuse me. V1, agree. 2, 3, 4, 5. And it looks like it wants to start down here.
And even in 1 a little bit
Yeah,
too.
and
While you're at
so
it.
remember, over here, you're
AVL.
going to look over to 1. Okay, because that's V5, V6, V1. Do I have any reciprocal changes here? Where would I look for reciprocal changes? Okay, here. And I got a little bit in 3, possibly. Yeah, I don't have a nice isoelectric line, so it's kind of hard to tell. I definitely don't have it in 2. Do I have a P with every QRS?
Yes.
It's hard to tell. My eyes jumped up to lead 1. I got a little bit of a first degree block there. Okay, you can see it right there. QRS complex narrow, yes. My QT looks less than 50%. Okay. T wave inversions, do we see any that we shouldn't see? Yeah, I'd agree that we've got to look. I mean, that is, we got a reciprocal. It's hard. That's a hard one to do. Okay. So, what's this injury pattern?
Antroseptal. Right?
It's yeah. I would do lateral too, because we got here and here. Anything I can answer back there? You guys good?
I was just asking what makes the trend of like 2 and 3, how it's trending downwards, the activity. I don't know if it's just like.
What do you mean by
water
trending down?
baseline or-
The isoelectric line going.
Yeah, it's not a good
starting-
isoelectric
going-
line. What makes it do that?
It could be something as simple as poor lead placement or adhering to the skin.
Okay.
Because everywhere else I'm pretty good. I've got a pretty nice isoelectric line. Maybe the lead isn't on that well. It could be that it could road noise. Who knows? You know, it's not a bad picture. I would still probably make the line that you could see it there. You know, if I was coming up here and I were to pick that line, I would say that right there is my. You can't really tell with me, but right there is my isoelectric line. Okay. Even though it's moving, it's not really significant for anything besides probably poor.
I don't know if that's indicative of one thing, you know, poor lead placement or bouncing on the road or
Yeah.
long-term trend, right?
No, I would. It doesn't pique my interest as being significant for anything. Okay. So let's go look at the next slide. All right. What jumps out at you guys on this one? So I heard someone say ST elevation in 1. Okay. Where else? I would say finding J point on here, because the way this swings down, I probably put the J point right there. Isoelectric line, so I've got some there. Do I have anything in 3? It's slight. It perks my interest. So if I know I've got there, I'm automatically going to go 2, 3 in AVF, and I've got both of these have a little bit of something going on, right? Mm-hmm. Do I have a P with every QRS?
Yes.
Yes.
Okay. Is my QRS narrow?
Yes.
Okay. Do I have a first degree or anything?
No.
Okay. And QTC and V2, is it prolonged at all?
No, it doesn't look like it.
All right, it looks less than 50%. What else?
Yeah, V3 is
So-
that elevation.
V3's got elevation, and it's got this weird little J wave coming in here. Okay, don't know if I wouldn't call it an Osborne wave, but just kind of piqued my interest a little bit. Any inverted T waves that shouldn't be there?
No.
Okay, so what kind of injury pattern is this?
Inferior.
Okay, are you concerned about V3, V4 at all? Possibly V5?
I mean, yeah.
Yeah, the morphology on the T waves is really strange.
It looks strange, you know, if I try to find that isoelectric line down here, I could say yes here, but I don't know if this is an Osborne wave. I don't know. I'd want to know the clinical picture. If they're cold, don't really know. But this one's hard to call ST elevation, and this one I would not call. So I would not say I have possible something going on here. So could this be a circ? You know, a left dominant heart. It has something going on over from the circ that's affecting the LAD, because you see right here we got a little bit of something, a little bit there. So this could be a left dominant heart that has things going on from the circ that are affecting the base of the heart here that's showing up. Does that make sense to you guys?
Mm-hmm.
So I wish I could give you a clear clinical picture, but this over here, because as soon as I saw that, I go over here and look, and I'm a little suspicious. So this could I mean, this could possibly be a left main that is affecting the LAD and the circ, and it's a left-sided dominant heart for the circ. Okay, so I would give diesel. Okay, so slide 5. What's your general impression looking at this?
A lot of elevation.
A lot of elevation
North
going
side
on.
heart.
Okay, so, you know, I automatically go over here just because we all start in the United States on the left when we read things. And I see this, I go down and I see I've got some here, I definitely got some here. But then I keep following that up, I'm like, well, I've got a lot going on here. Okay, so then I'm going to go, well, I've got this elevation. Do I have reciprocal changes in my inferior? Yes, I do. Okay, and then I've got some going in AVL. So I've got a lot of stuff going on here. So my first impression, if they're sick, I'm going to be treating that and looking at the EKG more later. But if I have time, all right, I got a P with every QRS. My P morphology looks pretty normal in lead 2. My QRS is narrow. I've got a flipped QRS complex. Okay, but I would call, what would you call this for an injury pattern? Anterior lateral reciprocal changes, and 3 in AVF. All right, how about this one?
So you've got elevation in 1 and AVL with reciprocal changes in 3 and AVF. So let's say high lateral.
If you look at 1, where should you look
Go to
next?
6.
Okay. Do I have elevation 6?
A little bit.
Yeah, we got something going on there.
And 5.
And then, excuse me, and then 5. Got something going on there. This is hard with the way this is curved right here, but this is pretty peaked pointed T wave too on there without elevation in the precordial leads. So is that hyperkalemia? Don't know. It's tacky, it's not slow. So to me, you know, with a really peaked pointed T wave, I should be a little bit slower. So I might discount that to some extent. But we definitively have reciprocal changes down here. Okay. I got a narrow QRS. Okay. I've got deep S waves though in the precordial leads. So what kind of injury pattern is that?
Lateral.
It's a lateral with reciprocal changes in the inferior leads. Okay. Does anyone have questions on these? Anyone getting overwhelmed? Okay. All right. Here's this one. What's your first impression? Okay, so I got some little bit of ST depression there. A little bit there actually too, yeah. A little bit there. B3. Yeah.
B3 through 6.
Yeah. I would say no. Okay. Is it fast or is it slow?
A little fast.
Okay. If you're using the boxes, so 300, 150, that's a little bit short, so maybe 130-ish, probably. Okay. PR interval. Okay. So go to lead 2, maybe a little short, because you look right there, how it doesn't really go back to the isoelectric line. That one definitively doesn't go back to the isoelectric line. Okay. So if I go down here and look at it a little bit more in a longer lead, that's kind of weird. So my PR interval, it looks variable to me. Okay. QRS.
No, it's the 3. It looks kind of wide. I don't know. How do you determine that?
What lead do we primarily look in for?
V1.
V1. Okay. So does it look wide in there?
No.
No. Okay. It's less than. QTC.
Less than half.
Less than half. I agree with that. Now, I see ischemia over here that we're talking about. I don't see any reciprocal changes. Maybe I need to jump on, okay, do I have a tall QRS? Yeah, it's kind of tall. Kind of tall, okay. Do I have S waves here? I do have S waves here, okay. So is this a left ventricular strain pattern? Typically you see it in V5, V6, but again, textbooks in real life can be different. So depending on their clinical presentation, could this be a strain pattern? Yeah. Would I, if they look sick, act sick, smelled sick, treat them as sick? I would. Because it's kind of progressing on to V3 through V6. But if it's just V5, V6, and they didn't smell sick to me, my spidey senses, as I call them, weren't tingling, then I would be less inclined to have a high index of suspicion. So this is, to me, this is sinus tach with a strain pattern. All right, what jumps out?
Elevation 2-3 ABF.
Okay.
5-6.
Okay. What else?
A lot of reciprocal changes.
Yeah, depression is the one.
Okay. So typically, you know, do I see anything that I got reciprocal changes here? So this is kind of a weird reciprocal changes to me. But this also jumped out at me. So I see this and I see this. What vessel do you think that could possibly be?
Right.
Possibly the circ, correct. So I would definitely look at RV4 and then treat away if I don't have elevation in RV4. You know, if I do have RV4, typically a circ isn't going to get to your right ventricle, but it's possible, but I've never seen it. The way you can get that is, say if you have a chronic, the occluded right coronary, you can get what's called collaterals. So your body is amazing in its ability to compensate for its deficiencies. So the left side of the heart, the vessels will get larger and extend more into the territory of the right. If this was like an acute, you know, closing off of the right coronary, your vessels don't have time to change. But if you have chronic kind of ischemic and it needs more blood, the left side of your heart, your circ and your LAD can extend and expand out and try to provide blood to the areas that it wasn't getting before. Human body is pretty amazing what it can do, you know, if it has the time to compensate. If it doesn't, then things go bad. All right. Check a pulse. Okay. What I like is that he's only got 9 PVCs.
That's about what I counted, yeah.
Yeah. I just started laughing. So, what is this over here? When you look at that.
That's VTAC.
All right. I heard someone say the correct answer. What did you just say?
It's torsades.
It is torsades. See, turning of the points, widening and narrowing, where VTAC will be pretty consistent. Bam, 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 bam. Okay. And a lot of times until we actually get on paper, when you're looking on a monitor, it's really hard to say torsades or not torsades. Not that we're going to treat it differently besides MAG. The rest of it's going to be the same. But that's torsades. All right, what do you guys see here?
Really fast.
It is really fast. That's a good first one.
At a glance, looks like SVT.
All right. Why do you say SVT?
It's regular. It's
Okay.
fast. It's right at that 150
Okay.
rate.
Yep. Do you see anything else going on in that one?
Looks like you have a strain pattern.
I don't. So if I'm looking up here, I don't see anything widen here. In AVL, I don't. Yeah, maybe. Because it's flipped. So I would say it's probably SVT with rate-dependent ischemia going on. So if you slow them down, I bet you some of that ischemia, or it could be a strain pattern. Does that make sense to everybody?
5, 6.
Well, but it's always good to learn. So don't feel bad about chiming in. I'm not going to pick on you too much. All right, what do we see here? Okay, so we see jumping out of me, because I start on the left always. I got some going on here. I jump down, 6, 5. Then I'm going, uh-oh, 4, 3, 2. Yeah, probably. Because that J point's probably right there, so yes. Okay, but I also have 2. I have AVL, maybe. No, probably not. But then I have no reciprocal changes. So what's that kind of injury pattern? This is lateral, this is anterior. So could be, because this, it could be a left main kind of issue. Because you got pretty much a whole left side, and then you got a little bit going on here. And the only reason you could possibly have a little bit going on here is just because the blood flow vessels could be nothing. But this is my concern. Here's a busy one. What jumps out? I heard someone say peaked T waves.
The hypertrophy
Yeah.
issue.
So strain pattern, I don't really have a large or QRS complex. And it normally gets progressively bigger in the V5, V6 range. So I would probably rule out a strain pattern. But I see over here, I definitely have some peaked T waves. Okay, my P, it looks pretty tall, might even be considered peaked. I'd probably say peaked there. My PR interval is not first degree. My QRS complex going up to V1, it's narrow, but I've got a flipped QRS complex. So I would probably call this hyperkalemia. Everyone agree with that?
Seems reasonable.
So you're basing it on a wide QR?
No, the hyperkalemia is a peaked pointed T wave. So see this right here?
Yeah.
Even though my QRS, I think that's probably an S wave. I can't see it. So
Yeah, it looks like it.
yeah, so this is, it's not flipped. I got a positive QRS right here, and then I have these big smoking T waves here, peaked pointed T's in the precordial leads. So, but I'd be looking for a clinical picture of, does this person likely have high potassium? How about this one?
It's irregular, it's AFib.
All right,
Depression issues.
all right,
Looks like a lateral.
all right. So then let's go into, so do we see P waves with every QRS? Let's just
Almost
walk
like a flutter.
Not consistent enough, but I can see it's irregular. I don't have P waves with every QRS. There's a bunch of stuff going on here. Okay. My QRS complex is a wide no. What else? Looking at my QT interval, it's less than half. I don't care at that point. But I start looking at this. I'm like, oh hey, look how tall that is. That's a big boy. Let's go see. Oh, I got S waves, big old S waves down here. Boom, boom. Big QRS complex getting progressively bigger in the V4 through V6. And look, boom, right there I've got a strain pattern. But when I look at 2, 3 AVF, just kind of looking at that, I see some elevation here, but I don't see it in concurrent leads. And then here, if I look at the isoelectric line and try to find my J point, there's nothing that's really impressing me. So I'd say AFib with the left ventricular strength pattern. Okay? And the only way you get better at these is do them a lot. Look at as many as you can. There's a really good website, I think it's called Life in the Fast Lane, that breaks a lot of this stuff down and gives you a lot. And actually Facebook, I think it's GEMS has a lot of 12 lead things if you like GEMS. And they always give you the ones that you're going to screw up, so I'm always getting them wrong because they're the random zebras of the world. All right, so let's look at this one. What do you guys see? Okay, I've got a white complex. I agree with that. It's slow. It's definitively slow. So that's the first thing that jumps out at me. Then, if it's slow, I'm going to look to see if this is a sinus brady or not. So I'm going to go down to lead 2. I've got a P there. 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 No QRS. No QRS. And I don't know what that is. Because then, so I don't think I have very good communication, and I've got a white complex. What is that?
3rd degree.
3rd degree block, correct. What do you see here? What jumps out at you?
Elevation 2-3 AVF.
Okay, so we've got here, boom. What else?
You have lateral reciprocal, or at least depression in 1 and AVL.
Yeah.
Yeah. 2, 3, 4, 5, I guess some elevation, certainly in B3.
It's hard to find a J point on here where I would call that J point if that's just a deep S wave. That's a difficult one. These are. Okay. But remember reciprocal changes for inferior right here. Boom. You got it. You know, it's an inferior. Roll with it. Do RV4 and treat accordingly. So, and if I had more time and cared in this picture, I'd look at the P wave, I'd look at my QRS complex, I'd look at my QT, you know, I'd look at those kind of things, but this is what's popping out for treatment for me. What's this one?
Paste.
Pace. Is it ventricle pace, atrial pace, or both?
Both.
Okay. Correct. So you understand why it's paced? If you're looking at this. Okay. When you look down here, do you see this little line and this little line?
Yeah.
Okay. Those are pacer spikes, internal pacer spikes. And the way you can tell it's atrial ventricle is obviously you got 2. If that's the P wave right there, that little teeny thing. You can see, let's see if I can find a better lead that shows it. And it's hard to see the P's here, but you think that the electrical activity of the atrium, because it's such a small muscle mass compared to your ventricle, is you're going to have less visible. But then I have a pacer spike and a widened QRS, so really indicative of being paced. Again here, we'll just do this one quickly. I've got boom, inferior, and I've got reciprocal changes to AVL. Can't say I've got anything there. Nothing else is really jumping out at me. I know I've got an inferior. How about this one?
Just a pulse check.
Pulse check. Yeah, those could this could either, to me, be end-stage hyperkalemia, or this can just be escape beats in asystole. So, okay, we're getting close.
Too much protein.
So, what do we see here?
It's overall slow.
I do, but do I have a P with every QRS? I don't have anything here. I do here. I don't there. I do here. I do. So there's Yeah, to me this is a junctional escape rhythm. You know, we're not going to get PR intervals because the morphology on the P's with the QRSs are all the same, but there's some miscommunication at the AB node that's causing this, and only some are getting through. Okay, really can't say much about this. Nothing really jumps out at me, screams at me for attention besides that they're in a third, which is enough. So, pearls. It takes time and takes practice. If you guys spend 10 minutes a day looking at EKGs, it helps. It's a simple thing, you know, even if the training guide sent out an EKG every week or two and, you know, did something for you if you get the right answer, first one to submit, and kind of make it a game where you get some for it. Always try to be systematic in it. It's really easy, and I do the same thing where I jump on something and I focus on it, and I have to draw back and try to look at the overall picture to see if I missed anything. You know, I can't emphasize enough, treat the patient, not the paper. The 12 lead is an adjunct to your assessment. It adds on, it allows you to kind of complete the circle, but don't use it by itself. And when in doubt, err on the side of caution, you know. Do what's best for the patient. Okay, any questions? All right, thanks guys.